So, good evening to all the viewers. We welcome all the viewers to the third edition of the Pediatric Spine Academy of India webinar, which is going to be about choosing LIV to prevent distal junctional failure in pediatric deformities. So, the talk is going to be started today by Dr. Ajoy Shetty, sir, who is going to give a brief introduction about the talk, as well as the speaker for the night, Dr. Saumyajit Basu, sir. So, over to you, Ajoy, sir.
Good evening to all of you. Thank you, Sharvin. At the outset, my sincere thanks for all of you to be here. Welcome you to the PSA webinar on LIV. The lower instrumented vertebra in scoliosis is one of the most important part in the surgical management of adolescent idiopathic scoliosis, also applicable to other types of scoliosis. We know that initially, when scoliosis instrumentation came into being, the Harrington stable zone was the one which was used, and invariably it led to a very good correction on the coronal plane. But however, we did understand that saving lumbar motion segments is very, very essential. It's applicable more so to curves which extend into the lumbar vertebra, like the type 3, type 4, type 5, and type 6, and also applicable to type 1C and type 2C curves. We now know at 10 years there may not be major difference, but as the years advance, over 20 to 30 years down the line, saving distal motion segments is very, very important for the long-term clinical and radiological outcome. I need not introduce Dr. Basu. I'm sure all of you know him well. Dr. Basu is the past president of the Association of Spine Surgeons of India, one of the renowned Indian spine surgeon. He has got a very special interest in pediatric spinal deformity. Without any further ado, I will like to invite Dr. Basu to give his talk on LIV selection, its important, and what is current in understanding and selection of the fusion levels. Over to you, Basu.
Thanks, Ajay, and thanks, Hriday, for inviting me to this beautiful evening. It is beautiful in the sense that I've been asked to cover virtually the entire aspect of pediatric deformities. So when Hriday wrote to me about a couple of months back that you should talk about choosing the distal fusion levels to avoid catastrophe of distal junctional failure, it was a very daunting task, and I don't know whether I can hold attention for 40 minutes. He asked me to speak for 40 minutes. I'm not sure whether I can be able to do that or not, but let's see, let's give it a try. I'm sharing my screen now. Can you see my screen, and am I audible?
Yes, sir.
Yeah, you are audible, and we are sharing. Yes.
So this talk is about choosing the lower instrumented vertebra to prevent distal junctional failure in pediatric deformities. So what I'll try to do is I'll try to capture as many clinical case examples as possible rather than going into the literature, because diving deep into the literature is basically getting to a system in which you can actually have literature for all you want to say. So today's talk would be basically based on LIV selection in AIS, which is the most important, confusing, and controversial part. And in AIS, I think one of the best examples of a proper template for LIV selection is given by Lenke in his classification system. It has stood the test of time for about 24 years now. It came out in 2002. And selective fusion especially has been the hallmark of his template. And as we go along the lecture, I'll try to sprinkle across a few clinical case examples to negotiate this particular fact of selective fusions. In non-AIS deformities, I'll just touch upon syndromic, congenital, and neuromuscular, and some special thoughts on EOS, because selection of fusion levels in EOS is basically dependent on a long-term planning after 10 or 12 or 15 years once the child goes into skeletal maturity. The planning has to be done at the time of 4 years, 5 years, or 6 years age. And finally, if time permits, I'll speak a little bit on choosing the distal fusion level in kyphotic deformities. So today is my scoliosis clinic. I just finished off my scoliosis clinic. I do a scoliosis clinic every 2 weeks in the afternoon. And this is a 3-month follow-up. The first X-ray they do after discharge is after 3 months. And two similar patients, one, the LIV selection was correct. And in the other, the LIV selection was possibly not correct, though we'll have to check out at 1 year. As you can see, there is a tilting of the lower end vertebra which is happening, and this might not be a very pleasing cosmetic figure once the child grows up. So the LIV selection is very important, and I think the Lenke classification is the most important classification which has actually given us a triad of system in which he has developed a curve type, a lumbar spine modifier, and a sagittal thoracic modifier. And this is the first time that the sagittal thoracic modifier has been looked upon in any classification system. So for us, the curve type, we know that there are 6 types of curves. I don't think I'll go into the details of this because the audience, most of them are mature spine surgeons, and they know that there are 6 types of curves. And there are 3 regions of the spine: the proximal thoracic, the main thoracic, and the thoracolumbar lumbar. And this is the proximal thoracic with apex at T3, 4, or 5, main thoracic T6, 2 to T11 disc, 11-12 disc, and the thoracolumbar lumbar, in which the thoracolumbar apex is between T12 and L1 for a thoracolumbar lumbar curve, and for the lumbar apex, it is anywhere between the L12 disc and L4. So that means if it is deep down, the L5 itself might get tilted, and the challenge comes up that do you choose L4 or do you choose L5 as the lower instrumented vertebra? So we know that the standard X-rays which has been recommended are upright coronal, upright sagittal, and left supine and right supine bending. In our institute, we do them supine as well as supine traction, but there are some institutes which do them standing. So basic principles of curve assessment is to identify the maximum curve, which is the major curve, in this case a thoracic curve of 60 degrees, and the minor curves, which are in this example a 26-degree proximal thoracic and a 45 degrees lumbar. And the convex bending view shows you that the 60 corrects to 35. That means it's pretty stiff. Whereas in the concave bending, you can find that the 45 corrects down to 26. And the 26-degree proximal thoracic corrects down to 5 degrees, which means that this lumbar curve is minor, but it is structural. Whereas the thoracic curve, which comes down to 5 degrees, is non-structural. So the minor curve can be structural and non-structural. And the LIV selection has to be based on the fact that you fuse the major curve as well as all structural minor curves. Now, if you look at these curve types, there are basically 2 types of curves. The C curves, which is the Lenke 1 and 5, either a major thoracic or a major thoracolumbar lumbar, and the S curves, which are 2, 3, and 6, in which there are 2 components of C's bringing up to an S. And finally, there is a triple major, which is a Lenke curve type 4, which is 3% in Lenke series. The other parts of the Lenke classification is something which was introduced first amongst many classification systems. That is, he made a clear understanding of the LIV based on a lumbar spine modifier. The lumbar spine curve, as you know, is very flexible, and there is where the real confusion and the controversy arises. And he developed the types A, B, and C, and the sagittal thoracic modifier as minus N or plus. We all know that the ABC modifier is when A is between the pedicles of the lumbar curve, of the apex of the lumbar curve. The CSVL should be touching the apical body or bodies in lumbar spine modifier B. And if the CSVL is completely medial to the lumbar apical vertebra, it is type C. And in this type C comes the maximum controversies in distal LIV selection. The thoracic profile also needs to be considered when you're really considering your distal LIV, because the hyperkyphotic curve, that means the more than 40 degrees, normal is 10 to 40, T5 to T12, but if it is more than 40, you should be very sure that you're not ending your fusion, that your LIV is not above a kyphotic disc, because that's where distal junctional failure is coming in. So Lenke classification looked at the thoracic sagittal profile, and as you see that this curve, which is a hyperkyphotic curve, which is 48 degrees, we brought it down to 32 on postoperative X-rays. So it is not only the selection of the LIV based on the lower part of the instrumented curve. You can see that this is L4, which is tilted right across, and so it stopped at L3, whereas here the L3 pedicle, L3 lower instrumented vertebra above a lordotic disc, and that's why we got away. In this case, you can see that the T12L1 is a similar case in which the sagittal profile was N minus 1.2, and bringing it back to 17.7 is a matter of choosing the LIV, because in the LIV you've chosen not to end it above a kyphotic disc space. Now we know that AIS has two types of curves, and if you look at the Lenke classification as a template for fusion levels, we need to understand that all LIV should be balanced over the sacrum. Now, if it is balanced over the sacrum, it can be a neutral, stable, or a horizontal vertebra. The concept is to fuse all major curves, all structural minor curves, and LIV should be balanced, that means the stable over the sacrum. Now, the next concept which Lenke and his fellow Eduardo Beauchamp brought in from the Harm study group was in 2020. That means the touched vertebra. 6 years down the line, this touched vertebra is also an important point still now considered in determining the LIV. Now, what is the touched vertebra? It can either be the LSTV, which is the last substantially touched vertebra, or the last touched vertebra, LTV. LTV is the cephalad-most lumbar vertebra, which is intersected by the CSVL at any portion of the vertebral body outline, including lateral to the pedicle. And if it is substantially touched, it has to be intersecting the pedicle or mirror to it. So if you look at this curve, lumbar 1, 2, 3, 4, 5, and the red mark is the CSVL. So you can find the pedicles of L1 and L2. In this, L1 is the last touched vertebra, whereas the last substantially touched vertebra is L2. And this is what is important, that it is safer to go down to L2 rather than L1. So here, the touched vertebra is an important concept in choosing the distal LIV. I would quote this article from the ISJ, one of the few articles in ISJ which Dr. Lenke himself has written, this fellow. And he has beautifully marked out how the LIV has developed in the last 4 decades or last 5 decades. In 1962, Harrington published fusing to the first caudal level in the stable zone, and Moe said that fusing was importantly to be the most neutral vertebra. 2 decades later, King came out with his publication in which he classified his King 1 to King 5 curves, and fusing to the vertebra most bisected by the CSVL was what he recommended. 20 years later, Suk challenged this and said that there has to be a concept of a neutral vertebra and an end vertebra. A couple of slides down the line, I'll show you how this works. So in the same article, he has given a table which summarizes the concepts in the LIV. From Suk in 2011 to 2017, there has been multiple publications based on the LIV. Suk in 2011 proposed that if the EV and the NV needs to be considered separately, EV is the end vertebra and NV is the neutral vertebra. Most of the times, the end vertebra is 1 or 2 above the NV. And if there is a difference between, say, EV is T12 and NV is L1, the neutral vertebra is L1, then you can stop down to the neutral vertebra. You have to go down to the neutral vertebra. You can't stop at the EV. Whereas if it is the same, the NV and the EV is the same, it can be stopped again at the end vertebra. But you need not go down to the neutral vertebra because they're the same. The problem arises when the neutral vertebra is way down. So for example, your end vertebra is T12 and your neutral vertebra is L3. Then you must have to go to L2. That means NV minus 1. That means you should, if the end vertebra and the neutral vertebra is far apart, you should try to reach the neutral vertebra as much as possible. But if they are close apart, you can stop at the end vertebra. By this time, the Lenki 1AR, Firoz Mianzi's classification came out in 2008, becoming Lenki 1AR and 1AN, which I'll 1AL, which I'll show you a slide below. So he could show that Lenki 1AR curves, that means the curves in which L4 was tilted to the right, were 2.3 times more likely to experience adding on. And Matsumoto shows that the maximum reduction of the apical translation of the main thoracic curve, an extension of the LIV to the last touched vertebra, avoids postoperative adding on. And the last publication which came out about 9 years back was from Lenki himself, and he could actually validate what Firoz Mianzi had said, is that if you really look at the LIV for Lenki curve type 1A and 2A curves, the optimization should be done by the touched vertebra concept. That means selecting the touched vertebra as the LIV for the Lenki type 1A and type 2A curves produce the optimum LIV selection positioning. And at 5 years follow-up, you could show that the LIV CSVL translation was the minimal if the touched vertebra concept was followed. So let's come on to some curves, C curves and S curves, to come into some clinical examples. 1 and 5 is easy because 1 is thoracic and 5 is lumbar. And this is Firoz Mianzi's publication in 2008, Spine, which came out that Lenki 1AL is L4 tilted to the left and Lenki 1AR is L4 tilted to the right. In these curves, the adding on is more frequent and you need to go very close down. You might go one more down. And here in 1AL, they are much more forgiving. You can stop short. This is a 17 female Lenki 1AL. That means if you see L4 is tilted to the left, not to the right. And so we went T4 to L1. This is the postoperative X-ray. And you can show a very good correction. Similarly, again, a C-shaped curve, 60-degree lumbar curve, you should go down to L4 rather than L3 because L3 is far away from the CSVL. Now, if you really go down to L4, that means you're doing a posterior surgery. Whereas if you really, this is a convex rod rotation technique, which I follow, and this is the postoperative X-ray in which we went from T10 to L4. Sorry, T11 to L4. And if you do the similar case in an anterior approach, maybe with a very good flexible L3-4 disc space, you can save a level by stopping at L3. Now from C curves, we go on to S curves, Lenki type 3 and 6 clinical examples, both thoracic and lumbar. And you can see that type 3 is when the thoracic curve is more and type 6 is when the lumbar curve is more. Give you a couple of examples. This is a 3BN curve in which we fused up to L4. We took out both the curves as in the fusion mass, preoperative and postoperative X-rays and clinical pictures. A similar clinical picture in which the lumbar curve was more. So there's a question of stopping at T10 and leave the thoracic curve or going up to the thoracic curve. In the bending films, if you see, this is quite flexible. You should go up to T4 and this is the final result. Now, finally, we come down to a double thoracic and a triple major. These are the two curves which are left out. That means the S plus C curve. The double thoracic curves are very difficult to correct because the left shoulder is looking up, then the right shoulder, and this, you can see this is a 62-degree curve, and even when correction comes down to 50, which is very, very rigid. And in this case, you have to go down below to L2 so that you get a horizontal L2 balanced over the horizontal pelvis. And here I could get 50% of the correction of the left shoulder up. Still, there is a little bit of left shoulder up, but if you consider it from the previous X-ray, previous clinical pictures, it's a lot better. And this is one of my very few type 4 curves, which were 3 curves. You can see that 92 thoracic, 40 proximal thoracic, and 60 lumbar. Put him on halo gravity traction, corrected the thoracic a little bit, but not the others. And so we went up to T2 to L4, and this was the clinical result. So now let's go on to selective fusion. That's the last part of the AIS, which I'm going to tell you. The Linky classification can serve as a very good template for selective thoracic fusion and a selective lumbar fusion. You know, when the side bending curve comes down to 25 degrees and the ABT-AVR ratio are less than greater than 1.2, you can do a selective thoracic fusion when the right shoulder is high and there is a minimal lumbar curve on bending forwards. Whereas a selective thoracolumbar fusion, neglecting the thoracic curve, is again with the left shoulder which is higher. That is one indication, and the thoracic rib prominence is acceptable to the patient, parent, and surgeon preoperatively, because the thoracic rib cage will undergo minimal change. So we must know that if you really fuse a lumbar curve alone, the thoracic curve might be 20 degrees residual, but there will be a significant thoracic hump which the parents must agree to. This is an example of a selective thoracic fusion, 60 and 36, 36 coming down to 22. So good, and of course a good derotation. This is also what I look at, whether there is a good derotation on the bending views of the lumbar curve or not. And here I fused up to L1, in which I left the thoracic curve to balance itself to 16 degrees. This is a 1-year follow-up. This is the preoperative pleasing clinical picture, and the patient happy, the parents are happy. But if you look at this patient, this patient was not initially quite happy to see the X-rays, because we did a selective lumbar fusion with a 72-degree and a 36-degree curve, and this 36 was coming down to 20 on bending films. So once 72 came down to 36, I counseled them regarding an anterior surgery and stopping at L3 and not going down to L4. Post-operatively, it looked as if this would add on, and the parents were not quite happy. But at 3 years follow-up, the patient as well as the parents were extremely happy, because she was extremely well balanced and cosmetically pleasing. So it is not only about curve correction, it is also about curve balancing, which steals the show. Now, I would like to end this AIS section with telling you about a very old paper, selection of fusion levels using torsional correction techniques, Doug Burton and Mark Asher. Never end fusion above a kyphotic disc space. This is one thing you should remember when you're choosing your LIV, especially if you're choosing a T12, L1, L2 region. And secondly, try to leave 3 or more distal motion segments. If not at L3, maximum go down to L4, but do not go to L5 or S1 in an AIS, because try to give them the maximum mobility of the lumbar spine in these young adolescent kids as much as they like to enjoy their lives. Now let us come down from AIS to syndromic scoliosis. Syndromic scoliosis is a bunch of deformities in which people might have terrible deformities, very stiff, to multiple skeletal deformities. You can see this patient with very stiff curve. In these cases, I would always prefer to go one down than L3. I would like to stop at L4, because these patients are stiff and many of them would add on if you really do not get into a proper perspective of curve correction. Marfan and NF, these are the 2 most prominent members of the syndromes associated with scoliosis. There is a list of syndromes: ED, muscular dystrophy, osteogenesis imperfecta, Prader-Willi, Rett, Angelman, but the commonest are the Marfans and the neurofibromatosis. A typical picture of the Marfans shows you the arachnodactyly, the long, slender arms, lean and thin. Many of them have lentil dislocation, root of aorta defects, and these are patients who should be worked up clinically. They have obviously hypermobile joints, and many of them would have scoliosis. Now, if you look at the principles of spinal fusion with Marfan syndrome, we must have a system in which you have to fuse primary curves if more than 45 and include all secondary curves more than 30. Maybe in AIS, you could leave secondary curves at 30, 35 if their side bending comes down to 20. But in these patients with high flexibility, they would add on. If a fusion extends to L4, consider it extends to the pelvis. If at all, there is a very severe kyphosis. Many of them have lumbar kyphosis. Give you a very old example of this patient, which was highly lordotic. You can see the thoracic spine is rather a lordotic rather than a kyphotic one. And in those days, we were doing anterior release followed by posterior instrumentations, and I went down to L2, and this was the patient preoperative and postoperatively. In these patients, if it was AIS, maybe I could have saved one more level, but for Marfan, you always go down. And in Marfan's, remember that they bleed a lot. In this particular patient, I had to leave the screws. I put in a halo gravity traction initially. I had to leave the screws because by the time she had already bled 2 liters and my anesthetist was hurrying up to close. I went back 7 days later and got this correction. And with multiple ponties, you can get a good correction. But again, you can see that L4 is still tilted. I chose L4 as the LIV because I left it tilted, but the pelvis is reasonably balanced because there is a small fractional curve here. This L4-5 disc space and the L5S1 disc space gives rise to a fractional curve, which actually compensates for the lower instrumented vertebral tilt. Ideally speaking, the LIV should be horizontal, the pelvis should be horizontal, and there should be no fractional curve. But in order to go down, in order to stop going down to L5, I stopped at L4 and accepted this fractional curve so that I could give her movement. This is the final picture. So 1 year follow-up. This is again a syndromic patient, and as you can see, she is reasonably good, flexible, and I went down to L4. A large hematoma. This is a hemihypertrophy. It's a gigantic right lower limb he has. This is again a syndromic variety. And he did initially very well. I went up to L4. A month back, he came down to see me. And this is 18 years follow-up in 2026. And you can see that the fractional curve has developed and this is added on. He is developing back pain, and it's only a matter of time. Within the next few years, he will land up a fusion to the pelvis. As had happened in this NF scoli patient, you see the LIV selection in this patient was correct. It was up to alpha, L4. And in the next 10 years, he came on a regular follow-up. This is an NF patient, and he really did well. He had a small PJK, which was not at all significant. It never actually bothered him. This PJK never bothered him, but what he came back to was a listhesis due to a significant degenerative changes here. And I don't know whether this was due to degenerative or whether there was a longer rod which was hitting the facet joint for 10 years. I'm not sure about this. I initially gave her a block, but he did not do well. He initially did well, and then the pain came back. So I did an extensional fusion at 2-level TILIF at 4-5 and 5-1 and went up to S2AI with a domino connector here. And he became quite well balanced. So far as sagittal balance was concerned, his PILL mismatch was corrected. And I left this small coronal imbalance or coronal curve upstairs because this was not bothering him at all. Now from syndromic scoliosis, let's come down to a few examples in congenital scoliosis. A 2-level hemivertebra. I'll first take up an example of hemivertebrectomy, whether you should really fuse short ends, use the distal selection, the distal LIV to be L3 or L4. I'll give you this example. 2 hemivertebrae need to be excised in this patient, as you can see, L1 and L2. And this is one of the few patients very early on. Then we used to do front and back. Took out the L1 and L2 vertebrae from the front, and then here I couldn't stop at L1. I went to L3. I went up to L4. because L3 was too much tilted and I couldn't risk. This is the 2 years follow-up, and you can see that there is a complete resection of the hemivertebra and very good correction. And this is the rib graph, iliac crest graph, which we had put in, which has got completely incorporated. But I did went down to L4. In very young kids, 3-year-old kids, I will just do a single level fusion because this is the best way to correct the spine without jeopardizing the rest of the growth of the spine, because these are very young kids where the growth of the spine as well as the pulmonary growth needs to be addressed. I have found this particular technique of transpedicular decancellation osteotomy very safe, very handy in patients like this who had 1, 2, 3, 4, 5 hemivertebra all clustered into one. And this patient, I decancellated all these 5 pedicles and went to 2 up and 2 down. And these are the 2 levels down. In this, I could save 50% of the thoracic spine from fusion. Here, if I had gone down to straight away T12, then it could have compromised the pulmonary function, because whatever pulmonary function remains in this 50% of thoracic growth remaining, I would try to preserve that. And this is a long-term follow-up. This is a patient who is a very devoted patient, goes on coming back to me at 5 years follow-up. He's still well balanced, and as you can see, this is her to start with, and this is what she came back with. And this is 9 years follow-up. Recently, she came again on a follow-up, and she's still doing well. In very severe stiff curves, you have to do a vertebral column resection. And here also, if we could stop a little bit lower down, here we could save 3 distal disc spaces. This is the best for her because she's young, and if she can have 3 distal disc spaces, that is the best. The correction is based on a cage, and this is the hemivertebrectomy which has been done as the VCR from the entire anterior aspect as well as the posterior aspect of the neural structures. Everything has been removed. This is the final X-ray, 70 degrees coming down to 18 degrees, and a sagittal curve of 17 degrees coming down to 20 degrees. But not all of them would require a VCR. I'll show you this example where I could not save levels because this patient had a huge curve, very, very stiff. He's 19, thoracic curve, 100 degree, absolutely stiff. Even in traction films, doesn't correct at all, and the lumbar curve is 60 degrees. So this is the secondary curve which could be corrected. And if we concentrate only on this, if I try to do a VCR, here I would in any case have to go down to L4. So in this case, I did not attempt a VCR at all, put her on traction, didn't correct well, just opened up a little bit of the lumbar curve. And so my decision was to go down to L4 and try to correct as much as possible the secondary curve. You can see that the secondary curve is spinning out, and that is what is leading to the maximum deformity. And this was the correctable part of the deformity. This was not. So I centered this deformity and I tried to correct the lumbar spine so that the thoracic and the lumbar spine match. And as you can see, that she had a good cosmetic result. Now let's come down to neuromuscular scoliosis. This is a very, very controversial aspect because most neuromuscular patients undergoing deformity correction is extended to the proximal thoracic spine. And there is a high incidence of significant pelvic obliquity in neuromuscular scoliosis patients, and the fusion is often extended distally to include the pelvis. Now, distal instrumentation to the pelvis in the case of a pre-existing pelvic obliquity is very safe option for a wheelchair-bound patient because the entire indication of surgery is based on whether he can be a sitter in a much more balanced fashion, or he tilts to one side during sitting and he can develop buttock sores and pain on sitting. So the restoration of sitting balance is very important, and pelvic obliquity is a hallmark of neuromuscular scoliosis, as you can see in this patient. His balance on sitting was excellent after the surgery. He enjoyed this surgery for 7 years and ultimately had a wound breakdown. This is a patient of multiple skin problems and ultimately had to take this implant out after 10 years. If they are non-walkers, Now, before that, for ambulators, many of them use their pelvis for ambulation. It is preferable to leave the pelvis in these kids, leaving at least 2 disc spaces below the LIV to give adequate balance and mobility. For walkers, if you capture the pelvis, I have burnt my fingers on a patient I'll show you. And she cursed me for 1 year completely because she lost her ambulation. And ultimately, our physio did a great job and could bring her back to a walker assisted ambulation. If they are non walkers, going down to the pelvis is better because of better sitting balance. There is some evidence that if it is a small curve, we do not get them in our country, then maybe leaving 1 disc space or 2 disc space, leaving going up to L4 and L5 works. But in the long run, if they live long enough, they are going to go down to the sacrum, the fusion. Now, I know that we know that these zones of pelvis are not going to this. I'll show you an example where I burnt my fingers. This is a post-polio patient, and I went down to L1, the pelvis. The pelvis was uncorrected. I couldn't correct the pelvis, and she went on from a walker to an initial non-walker. This is at 1 year. For full 1 year, she suffered. She couldn't walk because she's a polio patient and she was using a lot of her pelvic trunk motion and rotation in the lower lumbar spine to aid her walking. And this waddling gait disappeared after surgery. And ultimately, she was a very motivated lady and got back her ambulation on a walker after 1 year. But this is something which should be kept in mind, that for walkers, have a very strong discussion with the patient and the patient's relatives before you fuse them down to the pelvis. For severe rigid curves, you might use 3-column osteotomies or halogravity traction. This is a patient who is a walker. Polio, 14-year-old male, childhood polio, progressive deformed, very rigid. As you can see, the kyphosis is also very rigid. And this is a VCR I did for him. This is the cage over which I corrected after taking out the entire vertebra. And this is how he was after surgery. He remained a walker. He was happy. I was smarter not to go to the pelvis. And in those cases where neuromuscular scoliosis, this is a SMA patient whom you have to go to the pelvis. Very difficult initially because we put him on a 3 months of halogravity traction and ultimately could achieve a staged correction. You can see that our policy is to have T10 to pelvis in the first sitting and the next sitting go down up to T2 with domino connectors. These patients are very, very poor nutritional candidates. They have very high infection rates. Their complications are very high. Their albumin levels just disappear after surgery and their wound breakdown is so frequent. And in these patients, getting them back to a sitting position brings a lot of joy to them. And this is something which we should try to give them. This is the preoperative and the postoperative x-rays, 1 year follow-up. Now I'll have the last few minutes in early onset scoliosis and kyphosis. In early onset scoliosis, as you know, the non-operative treatment is mostly to buy time for progressive curves. You might have some patients who need fusion surgery, and only if in EOS your fusion is short, this works. You cannot fuse long because we have substantial evidence to prove that if you fuse long, they might have pulmonary restrictions and truncal shortening, which is not at all good for their health-related quality in their future life. Growth-friendly procedures can be destruction-based, growth-guided, or tension-based. The goals of surgery being correctional deformity, preventing curve progression, minimizing pulmonary problems, normalizing the growth of the spine, facilitate the care of the patient, and improve quality of life. Very long goals, very long follow-ups, 10, 12, 15 years. And that is why it is important to have a very strong discussion with the patients and the parents before you actually opt for treatment, that the parents should be there with you for at least 10 to 15 years before you start operating on these patients. Many of these would require a casting to start with, and many of these will require fusion surgery if it is short. This is one of the rare examples of a two-level hemivertebrectomy, one in the thoracolumbar lower thoracic spine and the other in the lumbar spine. Though they were oppositely placed, both of them were guaranteed to progress because both were fully segmented and both had Y-shaped open disc spaces. And this is the picture which is not very common. I have done only two in my life like this, with non-continuous hemivertebral excision, both single level. And this, the main focus is to make sure that the fusion is short and one up, one down should be sufficient. Now, growth-friendly spine implants can be distraction-based or guided growth or compression-based. I'll just show you a couple of examples to show you how do you choose the fusion levels. So this is a patient who came in at 1 year. I waited. At 2 years, it was 48 degrees. At 3 years, once it started to go to 60 degrees, I had to intervene. And I just took out, though there was a secondary curve developing in the lumbar spine, I just took out these two for hemivertebrae in the proximal thoracic spine and again waited. And this was a short fusion. The moment she's turned a little bit older, this curve started to spin out, and I used this fusion mass for a growing construct, and I put in L3 and L4. So because I had an apprehension that this patient ultimately would develop a long lumbar curve and we need to go down to L4 once she was 13 or 14 years. And so I chose my distal fusion levels at L3, 4, so that I have at least two disc spaces functioning and I can get a good control of the lumbar curve, which was bound to deteriorate once the child grows up. And this was after 6 expansions. You can see I still keep the lumbar curve under control. This is a 9-year-old female school-going child in which she was 70 at 9 years. So we can't let this patient go to 100 degrees by the time she's 12 or 13 and by the time she's attained 90% of her spinal growth. So I had a discussion with the parents that for the next 3 years, at least till she was 12, if I could just hang on with the growing implant, I think I could make a better outcome for her. They agreed. The patient's father was a doctor. And here, the choice was going up to L3 or going up to L4. So I thought that if we stop at L3, then maybe it will add on. And this is something, this is more like a Linky 1A R curve because it's developing into a right-sided tilt of L4. So I had no choice but to go down to L4. And this is the growing construct. And from 70, she came down to 30. Could control this for a few years. And then I ultimately did a long segment fusion, and as you can see that from T2 to L4 she was fused, and this was from 70 came down to 30 to came down to 12. Now the last few words about choosing the LIV in kyphotic deformities. Scheuermann's disease, other kyphotic deformities, it is very standard. There is a little bit of controversy and interesting thought processes in LIV selection for Scheuermann. This is not a very common surgery which you do. Maybe once in 2 or 3 years I would get to do a Scheuermann. And if it is a painless deformity with less than 60 degrees of kyphosis with stable asymptomatic kyphosis of any size, I don't operate. Whereas if it is cosmetically unacceptable, it's a progressive curve or a painful curve, and if there is a restrictive pulmonary disease, then it's an operative case. An example where I went down to L4, and because there was a huge curve, and this curve needed to go down to L4. Now, what are the principles of management of fusion levels? UIV is usually one above the upper end vertebra. LIV is usually one below the lower end vertebra. Now, LIV must go down to the SSV, which is the sagittal stable vertebra. If you drop a C7 plumb line or the sagittal vertical axis, the LIV must be best bisected by the sagittal stable vertebra, by the line, which is the sagittal stable vertebra. It is closely bisected by the sagittal vertebral axis or the C7 plumb line. And it is extremely important to avoid stopping at a junctional zone and never stop at a kyphotic disc space, above a kyphotic disc space, because that is going to produce TJK and implants will come out. Usually posterior approach suffices. Very rarely it is an anterior release. But in my fellowship days, 24 years back, people were doing front and back. I'll show you an example. Multiple periapical pontis osteotomy are done nowadays, and that usually is enough, because putting in thoracic screws at every level is now very safe, and correction is by cantilever technique and periapical compression. This is an example of multiple level. You can see these anterior cages, because those days one of my consultants was doing a front and back surgery, and this is a patient from Nottingham, and this was the final result with, you can see a big anterior scar and a big posterior scar. Nowadays, we would do a similar case with all posterior construct. This is a patient where the sagittal stable vertebra was L2, and so it is prudent to go down to L2. This is a patient from 61 developed to 69 degrees in 12 months, and he became continuously painful, and that's why he agreed for surgery. And as you can see that the Sorensen's criteria of multiple level disc degeneration and vertebral wedging is so very prominent in this case, which is actually the cause of back pain. Cantilever technique, multi-level osteotomies, pontis osteotomies at the apex, and compression at the apex with cantilever technique. That's the technique which we use, and this is how it looks like. Now, pre-operative and post-operative, he's now a medical student, and he's in his final year, comes back still painless, and let us see whether his lower limbar discs degenerate or not. So coming to the take-home messages, choosing the LIV in pediatric deformities, the most important thing is identifying the curve type and the etiology. If it is AIS, you need to consider the Lenke's principles. If it is congenital, then you need to save levels. If it is neuromuscular, try to avoid going down to the pelvis. If he's a walker, safely go down to the pelvis, and mandatorily do so if there is pelvic obliquity in a non-walker. And of course, in EOS, in Scheuermann's kyphosis, look at the stable vertebra. Identify the coronal end vertebra. If you're really doing a scoliosis, you must identify the coronal end vertebra. Look at the CSVL, identify the coronal stable vertebra. Look at the EV tilt and the fractional curve below it. As I told you in one of the examples, in many of the times, you will have to leave the LIV a little bit tilted so that the fractional curve below it can correct, but still you have two lumbar functioning discs. Horizontalization of the pelvis is crucial. If you leave a pelvis which is oblique after an AIS surgery, then the parents and the patients would not be happy, and it would be a few years where you have to go down to the pelvis. Now, identify the sagittal end vertebra when you are looking at a curve, especially for kyphosis. Look at the distal disc space, whether it is kyphotic, then obviously include that. Look at the SVA, identify the SSV in kyphotic deformities. But one part the literature is unclear about, whether PILL mismatch in pediatric deformities should be considered as important or not. Thanks for your attention. Stop sharing.
Thank you, Basu. An excellent talk. Actually, the two things, you stuck to time, you finished within 45 minutes, and you tried to cover every aspect of the pediatric deformity. It was an excellent talk. Thus, your selection, in case you need to operate on somebody who is immature in adolescent idiopathic scoliosis, what is your trick? I mean, is there anything different than what you have spoken so far?
Again, Ajay, I missed your question.
In a skeletally immature child, I mean, who is bordering maturity, does your LIV selection in AIS vary or still remains the same?
A very important question, very controversial. As I believe that if you're really operating on a child who is very flexible and young, the disc spaces which are not fusing have a lot of movement and they can really add on. Whereas somebody who is 16 or 15 who has little growth left, there the chances of adding on is much less. So in a younger child, though I would not like it from the core of my heart, but I would try to go a little bit lower down. And assured the parents that even if 2 discs are functioning, it should not be a major problem in the future. But if I can save 3 discs, I will go for it. But for a younger child, maybe I will take a risk of going a little bit lower.
Okay, thank you. And regarding my second question, you showed 2 case examples. The second one, there was a bit of a adding on or a coronal imbalance. What is your usual protocol in these group of patients? When you notice that there is some adding on, how long do you wait? Do you brace them? Do you advise them exercises?
Thanks, Ajay. That's why I started off with my 2 cases today. If you can see, usually my pictures are well cropped, but my fellow just mailed to me. I said in my Scoli clinic that I must have these patients 3 months follow-up, both similar type of patient. I must have them in my talk. So both of these patients, their parents are very, very bothered about the x-rays. Nowadays patients look at the x-rays, take pictures and put it on chat gpt and get an answer from the chat gpt whether it is okay or not. So first and foremost is reassurance that this is 3 months down the line, it is still early. And I would definitely do 2 things, especially that patient who was not very good looking. I mean, the patient who had a major chance of adding on. First is at least a 10-minute discussion with the parents that this might or might not progress. We don't know. We have to wait for at least a year, maybe 18 months to check out whether she really balances or not. In this 18 months, I would definitely brace her. And a Boston underarm brace is something which I would be very keenly following up. And in these patients, after 6 months, I will take an X-ray with and without a brace to see whether really brace is correcting or not. AP X-rays only. And if the pelvis is tilted, also many patients who the pelvis is also tilted, I will put them on an opposite shoe raise to see whether the pelvis neutralizes or not. Thirdly, which I would ask my physio to do, is build up on their mobilization exercises, because the more mobile the lower discs are, there is a chance that they will stabilize and they will develop an opposite curve in the lower lumbar spine. But if they're stiff and they're not exercising well, they're not bending forwards well, in those patients, they tend to be stiffer and stiffer and the curve adds on.
Okay. My last question. I'm sure that you're now using a lot of technology. Has it changed your practice in terms of LIV selection?
Technology in terms of
In
robots,
terms of navigation, robotics, or anything?
I don't use them. I was there for about a year. As you know, I was there in a hospital which had a robot, and I did a few cases of Scoli with a robot, and I was not very happy, because at least initially the workflow gets lengthened and the time taken is more, and my comfort level decreases once the robot comes in. And all my years I have done without a robot, and I still prefer to do without anything. I don't use navigation, I only use C-arms, but in all the complex deformity cases, especially the congenitals, especially the hugely deformed spines, the neurofibromatosis, I always have a 3D printout in my OT. I mean, I sterilize them with ETO and I keep them on the table whenever I'm operating, so they can have a look at around the spine in all directions and then check out and put the screws. So that has given me the best option without a navigation.
Thank you, Basu. Any questions from Sherwin, Hriday?
So, sir, extending on the question that Ajoy sir asked about young patients with AIS, if it's AI EOS and where you are planning growth rods, so do you plan on going a little shorter, expecting that when you want to plan a final surgery, you might have to extend the fusion lower down?
I showed you in an example that I intentionally went down to L3-4. First of all, most of my patients, L3 and L4 are the 2 lower screws, because that is my fusion mass through which, and the AVAV is T2 and T3, where I would put in my growing rod. Correct. I mean, the growing rod fusion mass, the upper fusion mass is at T2 to 3 and the lower fusion mass at L3 and L4. There are few patients where I might go to L2 and L3, but I don't think I've ever gone to T12 alone. One of the main reasons being I have to place the connector. whatsoever smaller connector it is at the level of the thoracolumbar spine, which is a straight part of the spine. And that part means that if I go up to L2 and L3 as my lower fusion mass, if I leave at least an inch of rod for further corrections, because I always do my expansions on the lumbar rod, they are usually much more robust and much more forgiving so far as pulling out is concerned. And these patients do not have enough rod left if you are really looking at L2 and L3. You always struggle for putting in the connector at the place. And I don't know, I am not very comfortable at this. So most of my patients, I go down to L3, L4.
Arjun?
So it was a exceptionally good talk. Thank you very much. And so do you use only the standing films for your decisions? I mean, basically, are you using only the standing films? Or are you using supine films sometimes? Because I didn't think you were using bending films at all. So
I always have bending
Can I
films.
add to that
Yes.
question so that Basu can answer that? So whether you use a traction film or you change your decision with the traction under anesthesia or sometimes like that. So you can just add on, so don't waste time.
Okay, so all my AIS, I do bending films and supine traction films. All my AIS. My standard protocol is a supine AP bending films and a supine traction film, not on GA. In my adult deformities, I have stopped doing bending films. I do a supine traction AP, and after much discussions with the management and much more adjustments in the radiology department, I have now been able to set up a supine lateral whole spine X-ray. So a supine lateral and a supine AP in traction is one thing I would do for my adult deformities. I don't do bendings anymore. But for all my pediatric patients, I would do a supine right and left AP bending and a supine traction. I don't do GA traction.
and your decision making is based on like the substantially touched vertebra on the supine or with the
For
stand?
AIS,
Yeah.
for AIS, all my selection levels are based on standing AP films. I look at AP bending films only to assess curve flexibility and the amount of motion the lower disc spaces have if I am doing an anterior. I do not, in fact, there's a lot of controversy regarding the Cobb angle. I have a major fight with many of them who say that the Cobb angle vertebra changes or the Cobb angle vertebra doesn't change and all that. But I always base my LIV selection or my fusion levels based on standing AP films, not on supine films. But the flexibility of the lower disc spaces and the flexibility of the curve and identifying the curve pattern is something which I rely upon with those supine films.
Thank you, sir.
Do you do any special maneuver to squeeze the lower vertebra from L4 to L3 for operative?
Squeeze means?
That means you do any derotation maneuver to get one segment, say one segment by posterior.
Give me a case scenario.
Supposing you know that it is lanky 5, maybe that's the main area where we want to go from L4 to L3. L5 is, of course, never possible. But you want to stop at L3 instead of L4. And then you do any derotation of the L4 vertebra or L3 vertebra so that the horizontalization occurs, or you take the X-ray during that time and see whether the L3-4 has horizontalized or not. And then you stop.
Excellent question. Excellent question, Amit. So I'll give you two case examples. One is a standard T10 to L4 for a posterior fusion for a Lenki 5C curve. In that, first of all, I put in screws at all levels. I will put in the screws. In the convexity, I do a convex rod rotation. I use monoaxial screws at the apical part. T10, 11, especially at L1, L2, T10, 11, I might put in poly. L1, L2, L3, I would put in mono screws. So that's where my maximum convex derotation happens. L5, I'll put in a poly. Yes, poly. Because it is L5 is very lordotic. L4, sorry, L4 is very lordotic. It's deep down. So I would try to put in a poly. Now, when I am done with my correction, I put in the convex rod first, then the concave rod. When I am done with the correction, always I would bring in a C-arm to see the lower levels, whether they have horizontalized or not. And when I'm doing a thoracic fusion, I'd see whether the T1 is horizontal or not in the Lenki 5C curves. Now, if I am left with a L4, which is not very horizontal, then I would do a little bit of compression distraction on the convexity concavity to make it horizontal. Now, when I'm going to L3, first of all, I rarely go to L3 if I'm doing a posterior for a Lenki 5C. If I'm doing an anterior, then I will go to L3. I will disregard the CSVL and the last touched vertebra concept, because these concepts doesn't work for an anterior fusion. The anterior fusion is basically a periapical fusion. You just fuse the apex and leave the rest for naturally balancing it. So it's more of a balancing type of surgery. So I just go to L3, do the maximum derotation possible, and leave it. I would not be very keen to take an intraoperative X-ray also to see whether L4 is horizontal or not, because in that position it doesn't make sense. I don't know whether the answer was adequate or not, Amit.
No, perfect, fine. I just wanted to.
I mean, do you do anything particular to save motion segments?
So sometimes when we put in the patient prone and under anesthesia, we feel that we have selected L4. But under anesthesia, we feel that it is already horizontalized at L3 for sometimes. And then we do a derotation much more and check under GA. And then we may stop at L3-4. That's sometimes a per-op decision which changes. So that's the reason that I was asking.
But I have never changed my decision. All my patients have a preoperative decision, which hardly, I think, less than 5% chance that I will change my decision.
Most of our is also the same, but sometimes this happens in a borderline or borderline cases where you feel that you want to squeeze.
Recently, I read an interesting article from China, wherein they go up to L4 without damaging the facet joint, do the correction at about 6 to 9 months. They
and
go
take
in
out the screw. Yes.
And Ian, I think one of the American surgeons uses it temporarily intraoperatively and then remove it and keeps L3 as the end vertebra. I have not used it, but it's quite interesting to know that people use different techniques to save motion segments. I think, Rida, you can close if there is no questions.
We have one question from the audience on our YouTube. So we have two questions actually. So we have a question from Dr. Avtar Balawat that in AIS, have you ever gone to L5?
I think I'll share with you a very funny story. So in one of my patients, this was my initial possibly 5 or 6 years into practice. I had a patient whom I went down to L4, and I felt that there were 2 disc spaces. In 2010, I visited Lenki's place. I was there for about a month, and then in one of the case discussion session, I put this patient up, and I said, this patient, Dr. Lenki, is not happy because she is tilted over to one side. But still, I went down to L4. How can I go down more below? And then he looked up at the X-ray and told me, Basu, I think you failed to realize that there is no movement at L5S1. L5S1 is a very rudimentary disc. And there is no movement. So it is basically a sacralized L5. So we've actually left only one disc space which is unable to control your coronal tilt. So I then realized, I went back to my original X-rays and I saw that this was correct. And in that patient, I had to go back and do an L4 PSO, went down to the pelvis and corrected the tilt. And that is the only time I have gone down to L5 unknowingly.
And we have a question from Dr. Ranjit Krishnan. that what info we get from supine lateral X-rays, and does distal vertebral body wedging change your LIV?
Supine lateral X-rays is for my adult patients. In those adult patients they have a lot of thoracolumbar kyphosis, I just see whether that is rigid or that is not rigid. That's the only time I use the supine lateral X-rays. And the second question was, Hriday, I missed.
Yeah, the second question is that does distal vertebral body wedging change your LIV?
Distal vertebral body wedging is usually at the apical regions. The end vertebrae are not wedged. If they are wedged, I would be very skeptical about this because I might be missing out a congenital anomaly. But they do not change my decision.
So he has just writing on that. For example, if your LIV as per plan is to go to L3, and the L3-4 disc is parallel, but L4 body is wedged, in that case, does your plan change?
The planning is based on a preoperative standing X-ray. If my preoperative standing X-ray shows that L4 is horizontal, L3 is tilted, and even if it is wedged, if I can horizontalize L3 during my surgery, get up the C-arm to show that L3 and pelvis are parallel, then I would neglect the wedging.
Can I have one last question before we wrap up the?
Absolutely.
So do you think the degree of L5 tilt, does that play any role in LIV selection in type 5 or 6 lanky curves?
So that plays a very important role in understanding the fractional curve. If I stop at L4 and leave L4 10 or 20 or 15 degrees tilted, and that 15 degrees is the fractional curve in which the pelvis becomes horizontal, then I would have that to my benefit.
Because
So
sometimes
that is
the
where I
L5
would
is-
try to look at the L5 tilt. If L4 is, for example, the patient stands up with a L3 tilted at say 25 degrees or 30 degrees, and there is a fractional curve. Now, once I get the tilt down to say from 30 to 15 degrees, and the fractional curve is 15 degrees, 20 degrees, then they balance very well. As I showed you an example. But this, in my 18 years follow-up in the last month, I learned in this syndromic scoli that even after so late, they can go off balance. She was so excellently balanced for the 10, 15 years that I followed up. And for the last 5 years, he was not under follow-up. And he came again after 5 years. He changed his job and he started to have pain. And came and asked me, and I saw in the X-ray that the fractional curve is no more functioning well. And so that's why he's getting out of balance. And that's why he's having a painful disc.
Thank you, sir. I think it was an excellent talk by Basu sir about the LIV selection. And Rita, do we have any further questions from the audience?
No, we are done from questions from the audience.
So our next webinar is going to be by Dr. Saumyajit sir, who is going to be talking about a very important topic on the importance of sagittal balance in scoliosis, which will be on the 5th of August. And this time it is going to be on a Wednesday instead of our routine Thursdays for at the same time. Thank you to all thank you, Basu sir, for giving your valuable time and an excellent talk on one of the most important topics of EIS. Thank you all faculty, Ajoy sir, Jhala sir, and all the organizers. Thank you for Ortho TV for the broadcast as well.
Thanks for the opportunity, Hriday.
Thank you, sir.
Good night, everyone.
Good night.
Good night.
Night.
Amit.